Okay, our next speaker is Dr. Philip Saba, neuroradiologist extraordinaire. He joined Wake Radiology in 2001. In addition to being board certified, he holds a certificate of added qualifications in neuroradiology. Dr. Saba is a native of Pittsburgh. He graduated from the University of Pittsburgh School of Medicine and then completed 3 years of a psychiatry residency at the University of Pittsburgh Medical Center with a special interest in child psychiatry before beginning his residency in diagnostic radiology at the Mercy Hospital of Pittsburgh. So you can guess which professional football team he roots for. After his residency, he completed a 2-year neuroradiology fellowship at the Barrow Neurological Institute in Phoenix, Arizona. By virtue of his training and qualifications, Dr. Saba holds senior member status in the American Society of Neuroradiology. And when he's not at work, he loves spending time with his family and making music. He's one of the smartest guys I know. He's a dear friend of mine. And today he's going to be comparing and contrasting CT and MRI as they relate to some common neurological problems. Please welcome Dr. Saba.
We okay? Are we on now? Okay, great. Thank you, Bill. Thanks very much. It's very flattering. I appreciate that. Good morning, everybody. It's great to be here, and thank you very much for coming. What I'm going to talk to you about today is choosing between CT and MRI in different neurological situations. And rather than, excuse me, okay, we're good? Okay. Rather than sort of giving you a list, should I be pointing? Where should I be pointing?
To the table, right?
Okay, good. Maybe I'll get close to you here. Okay. Rather than basically giving you just a list of, things to memorize, this is better for CT, this is better for MRI, I want you to understand, why each is better or worse in a given situation. So to do that, we're going to talk about, what is CT and what is MRI, which is better for an indication, which is worse. And, essentially the same question is, what are the advantages and disadvantages of each? And to understand that, you need to understand a little bit about how they work. And, I know that, you're not here because you're training to become a radiologist or a radiology technologist, but I think if you understand a little bit more about how these machines work, it'll help you not only with neurological indications, but any abnormalities, any pathology in your patients that you find, you can be more informed about what kind of test is going to give you the information you're looking for. So CT, as we used to call CAT scans, but now CT scans. CT stands for computed tomography. And this is, I'm going to present this to you in contrast to what I'm going to refer to here as old school tomography, okay, which is the tomograms that were used very commonly up until, let's say about 10 years ago when, we got to the point where when the tomogram machine would break down, we wouldn't bother fixing it anymore and we'd kind of let it die on the vine. In old school tomography, basically what's happening there, and you might recall, like for instance with IVPs, that was probably the most common place where you would see a tomogram, is what we're trying to accomplish there is we're trying to show an image where everything that is in a certain place is in focus and everything else is out of focus so that you can look at that one thing. And the way that was accomplished was there was an X-ray tube and there was a piece of film, and the film was on a little cart that would go back and forth, and the tube was on a big arm that would go back and forth. The patient is here, and as the tube would go here, can you hear me okay? Is that all right? Because I think when I turn my head, maybe you can't hear me as much. Let me move this up. I'm going to put this, flip this over here. Let's see. There we go. Yeah, because I think my head's going to be turned this way most of the time. So, okay, so as the tube would go this way, the film would go this way. Basically, the only point that intersects is right here. So this, whatever's at this level would be in focus, and whatever's in front or behind it would be out of focus. So you can imagine, not just for this one point in space, but actually for this whole plane in the patient, As the film goes this way and the tube goes that way, you end up with an image where everything in front of that is out of focus and everything behind it is out of focus, and the only stuff that's in focus is the stuff that's at this particular height off the table. And for tomograms, we would pick like 9, 10, 11 centimeters to get the kidneys in focus, but everything else in the abdomen out of focus. And this is just an example of like an old tomogram of the TMJ. You can see it's not a great picture, but it's certainly better than looking at like a lateral x-ray of the skull. You get a lot more detail about the actual structure you want to look at. Well, that's what tomography was in an analog sense. But with the advent of computers and the explosion of computer technology, that was expanded to computed tomography, which is more of a sort of a digital application of the old analog tomogram. And this is kind of a neat, this is a neat picture that I like, where this is, now CT was invented by Sir Godfrey Hounsfield, an Englishman, in 1972. And this is actually his first drawing where he was sort of working this whole thing out. And this is his first mock-up here in the lab, where he's got this gross specimen of a brain inside a big slab of plastic, and he's got this sort of primitive CT scanner that he's rigged up in the lab. And the way CT works is that, if you can imagine, here's the patient kind of cutting cross-section, and here's like some object, let's say it's a lung nodule. If you project that X-ray beam through from different angles, it's going to create different pictures depending on where that beam is coming from. So in other words, if you get these three pictures and you summate them, you put the three of them together, you're basically going to get this. And then when you kind of work backwards with some mathematical algorithms, you get this, which is a sort of a depiction of what you were actually looking at in three-dimensional space. So here's a typical CT picture. This is a head CT without contrast, and you can see that we have here the brain and this middle cerebral arteries and the cerebral peduncles, and you can see the skull and extracranial soft tissues. Well, the way that that is done, it's done by massive numbers of calculations, and of course those are things that can only be done by computers, and as the computers become more powerful, the CT scanners have become more powerful as well. And CT scanners have gone through sort of several generations of technology. Initially, the first idea was to have the X-ray tube and then a detector opposite, and the two of them would kind of swing around like this opposite each other. And then somebody said, well, let's put more detectors there, and let's kind of open it up so that the thing doesn't have to go all the way around, so that the tube doesn't have to go all the way around because we have more detectors. And then somebody said, well, I got a better idea. Let's put a ring of detectors all the way around and just have the tube rotate. So, you have fewer moving parts at that point, and also that enables you to do a faster scan. Well, this was sort of the third generation of CT scanners, and that takes us to what we're using today, which is helical or spiral CT. Now, in all the previous versions of CT, it was essentially a step-and-shoot kind of technology where the tube and the detector would go around the patient, and then the table would move, say like whatever we prescribed at 5 millimeters, and then it would happen again, and the table would move, and then it would happen again, and the table would move. And this was a very kind of laborious process, and it would take a long time to get a CT scan out of that. And plus, you were then sort of limited to whatever slice thickness you chose, and you were also pretty limited to anything outside the axial plane, because the images would then start to look real kind of stepwise, and they wouldn't be smooth if you did anything other than a straight axial. Well, with helical scanning, what we're doing is the tube and the detector are rotating as the patient is moving continually through the scanner. So what you're actually acquiring is you're acquiring a three-dimensional data set, which then enables you to go back and reconstruct those axial images at any thickness that you want. And since it's actually a volumetric data set, you're obtaining a volume of data instead of a bunch of slices, you can go back and reconstruct that data in any plane and have it look, equally pretty as the axial image. So in other words, if you've looked at, like, for instance, a renal colic CT, when we show you the coronal reformat of that, it looks just as pretty as the axial image. It looks as if we scanned the patient, as if they went through the scanner like this, standing up, and the thing going around them this way. because it all has the same spatial resolution. Well, when Hounsfield worked out CT, basically there was a unit named after him, Hounsfield units, and these are units of density on the CT. And they basically, I won't go into too much detail other than to say they range from about negative 1,000 for air to positive 1,000 for bone, and the machine is calibrated so that water is in the middle. And you remember that fat is less dense than water. It floats, right? So the density of fat is around negative 80. And then a couple structures that are near to my heart are gray matter and white matter, which you can see are pretty close in density. And then blood, which is also very close in density. So these are three things that when we're doing a head CT are going to look very similar unless we do certain things to the image. So when we generate a CT image, basically what we do is we come up with a grayscale and we designate where black is going to be the least dense and white is the most dense. And as humans, we can distinguish about 128 shades of gray, believe it or not. Now, the 3 megapixel monitors that we use for diagnostic purposes to look at the images can actually show over 1,000 shades of gray. That comes into play more with looking at plain films, plain radiographs than it does with CT. It's kind of overkill for looking at CTs. But essentially, if you can imagine a grayscale, black to white, and then you pair that up with a range of densities, a range of CT densities. And you can pair that up however you want to pair it up. So, for instance, as I mentioned before, what are we going to do if we look at a head CT image and we're trying to distinguish gray matter and white matter, and the densities of each are 30 and 40 Hounsfield units, we're really not going to be able to tell those things apart. Well, what we do is we manipulate what's called the window and the level, okay, where we pick basically a middle for that gray range and we pick a range for the gray scale. And that helps us look at different aspects of the same CT image. So I want you to remember one big difference between CT and MRI is that with CT, we're scanning the patient once, essentially. I mean, assuming we're not also going to go back and do it with contrast. If it's like an unenhanced head CT, it's one CT, but then we go back and we look at that same data several different ways, okay, which is different from MRI, as you'll see. But with CT, we'll use commonly these windows and levels. Again, the level is the middle of the grayscale. The window is the range. So let me show you some examples of what that means. Now, if you just open up the thing wide open and you don't designate any window or level, essentially you're going to say, let's say that 0 is going to be the middle. Water is going to be the middle of your grayscale. And you're going to say the whole range, 5,000. You basically get an image like this, which is not very helpful. You can see some bone detail, but certainly you can't make out anything going on in the brain. You can't tell brain from CSF. You would never see a brain tumor in this image. You would never see a massive hemorrhage in this image. So again, what we do is we go back with this same set of data and we look at it a different way. We say, okay, let's put the middle of that grayscale at 40. And let's give it a range, let's give it a window of 80, so that anything less than 0 Hounsfield units is just going to be black. No matter whether it's fat or air, it's going to be black. And anything more dense than 80 is going to be white, white, white. So whether it's calcium or bone or some like dense marrow or something, it's all just going to be white. Okay, so you're basically saying, I don't care about this stuff, I don't care about this stuff, I just want to look at the brain. And then, so that's called a brain window. So that gives you an image like that. And that's, again, this is the same scan that you saw a moment ago, but now just looking at it with designating that grayscale in a different place depending on the density of the tissue you want to look at. So again, the middle is 40 and the range is 80. So here's another example. Now, knowing what you know so far, let's say we put the middle of the grayscale at 35. And let's say we open up the range, we're going to call the window 320. Okay, well, what kind of image will this give us? This gives us what we call a blood window. And this image is very nice for picking up, small subdural hematomas. And the reason is it doesn't give you a particularly nice look at the brain. Of course, this is aesthetically not a great image, but what it does help you pick up, and there is not one here, but I'm using this because it's the same CT we've been looking at all along. If there were a small subdural hematoma, say like just 2 or 3 millimeters thick, you could pick that up against the inner table of the skull. Whereas if you were looking at that brain window image, the one that looks like a nice picture of the brain, you might not be able to distinguish the subdural hematoma from the skull next to it because they'd both be like white, white, white. Okay, so again, same data, same scan. We only scanned the patient once, but we go back and we look at it in different ways. So knowing what you know about the densities, what do you think, what kind of image do you think you would get if you put the middle of that range at 500 and you opened up that window to 2,000? In other words, what's relatively dense on the image? The bones, right? So in this case, you get what's called a bone window. So again, the same CT, but now we're doing it because we want to see the bony detail. And this, of course, we would use, if we were concerned that there might be a skull fracture. We use this when we're looking at the sinuses. We use this, for temporal bones, any kind of intrinsic bone lesion in the skull. So again, all of them came from the same unenhanced head CT, but it's all afterwards what we do as radiologists in manipulating the image to look for what we want to look for. And I will also say that those windows and levels are just starting points because when we're interpreting the images, we're always interacting with the image and kind of fine-tuning that and pushing it around and opening and, to get the things to look exactly optimal for what we're trying to look for. Well, here's an example of pathology, of an abnormality here on a brain window. Here it is on the blood window. Here it is on the bone window. And here it is. This is a different window that we use called a stroke window, where we basically put the middle of that grayscale at 37, and we make the range 37. And it gives a very ugly picture of the brain. I mean, it's not an aesthetically pleasing head CT at all. But we do this as radiologists because what it does show us is it's very sensitive for showing an early infarct. Because what happens is, you remember the gray matter is around 40 Hounsfield units and the white matter is around 30. Well, when the gray matter becomes edematous during an infarct, you have edema in the cortex, water comes in, and as water, remember, which is 0 Hounsfield units, as the tissue becomes edematous, it goes down in density, right? So the cortex becomes a little less dense, and it goes from 40 down to about where the white matter is, which is about 30. So what you'll see is you'll actually see an area where the cortex kind of goes along like a sort of a slightly more white stripe than the white matter, but then all of a sudden it becomes the same as the white matter, and you just see like this kind of dark gray that goes all the way out to the surface of the brain. That's a very, very subtle finding in the very, very early stages of an infarct. Now, of course, later it's going to, encephalomalacia will set in and it just becomes, like necrotic tissue. But in the very, very early stages when it's just edema, that's what you'll see. So on an image like this, it's not a very pretty picture, but it's the most sensitive way to detect a very subtle infarct. And I'll show you an example of infarct later. So basically, with CT, we're distinguishing different types of tissue by their actual physical density, okay, essentially by their atomic number, by how much they attenuate the X-ray beam. In the same way that on a traditional X-ray, bone is white and air is black because it's attenuating, it's stopping that X-ray beam, and the film, in this case not film anymore, but the film on the other side is less exposed by something that attenuates the beam. So it's very analog sort of imaging, even though it's an order of magnitude more complicated, or 2 orders of magnitude more complicated than traditional tomograms. And I won't belabor the second point because we've already talked a lot about that. So now, moving on from CT. So now you understand a little bit about how CT works. So what is MRI? Well, this is a typical MRI picture in neuroradiology. This is an axial T1 weighted image of the brain with contrast. You can see here the contrast in the transverse sinuses. And you can see here this lesion. This is the lesion that we just saw on that head CT a moment ago. So this is that patient's MRI. Well, as far as answering the question of MRI, I can tell you that it's a lot more complicated than CT, and to explain it goes, well beyond the scope of today's discussion. And as an attending of mine used to say, and I think it was true, he used to say that you'd go to a lecture on one certain aspect of MRI, And the first time you went to the lecture, the whole thing would just be completely over your head. You wouldn't understand any of it. The second time you went, you'd start to at least recognize some of the terms. And the third time you went, you might start to understand some of it. And, long story short, you'd have to sit through the same lecture about 5 times before you had like a grasp, or half an hour later, you could actually reproduce what you heard. There's that stage in the middle where you understand it as they're explaining it, but then like a half an hour after the lecture, you're like, you can't explain it, you have no idea anymore. That's somewhere around the 3rd or 4th lecture. And so when you get into like the same lecture 5, 6, 7 times, then you actually start to retain it an hour later. So we'll skip over how it works for now. It is not magic realistic imaging. It is magnetic resonance imaging, and just a little trivia for those of you who remember, when it first came out, it was called NMR, for nuclear magnetic resonance. And the marketing people were smart enough to pick up on the fact early on that nuclear scared people away. And also that they had this great advantage with MRI that there's no ionizing radiation. And they put nuclear in the name, and it made people think that there was radiation associated with the procedure. And so they were basically shooting themselves in the foot by, hiding one of the biggest points to tout about MRI. So they appropriately changed the name early on to magnetic resonance imaging. In MRI, basically what we're doing is we're depicting different tissues based on the density of proton atoms that are in that tissue. So you might have like a cubic millimeter of water. You might have a cubic millimeter of cortical bone, of bone cortex. Both of those have a very different number of free protons in them, and the protons essentially equate with water in this model. Wherever you see the proton molecules, it's kind of like thinking, well, what is the amount of water in that tissue in a sense? And that's how you're distinguishing the different tissues. It's not by density anymore. It's not by its sort of physical attenuation of the beam. It's by its more of its chemical composition. And the way the MRI works is that essentially there's this giant supercooled magnet that is shaped like a tube, okay? And that magnet is never turned off. Like, in the middle of the night, it's still on. That's why you hear these stories about, like, the guy who comes in with the floor waxer in the middle of the night, and he comes in, and there's nobody around. He's in the MRI department. He walks into the room with the scanner, and the 500-pound thing gets lifted off the ground, sucked into the bore of the magnet, and then they have to do what's called quenching the magnet, which basically means draining all the liquid hydrogen from the outside the magnet, shutting the thing down for 2 weeks to get that thing out of there, because you can't turn that magnet off. There's that big magnet. Now, inside that magnet is another sort of, basically another set of magnets. What happens is the patient goes inside that tube, and there are these things called gradients that essentially fine-tune the magnetic field inside that bore so that it's slightly different from left to right, from front to back, and from head to toe. So in other words, the magnetic field inside that bore is not exactly the same everywhere. It has a slight gradient, again, from left to right, front to back, top to bottom. So you can imagine in three-dimensional space, the magnetic field on the back of my right foot, what the magnetic field strength is there, is slightly different than the magnetic field like on the front of my opposite hand, because we've got all sort of 3 planes involved there. Well, how does that help? Well, what happens is the patient goes in there, you've got this second set of magnets, right? The big magnet will, by virtue of the patient being in there, it imparts an energy, a radio frequency, to these hydrogen molecules, and they'll vibrate. They'll vibrate at a certain frequency depending on where they are in that 3-dimensional space. Okay? Now, the other set of magnets will kind of impart sort of a second radio frequency that'll kind of knock those atoms over, kind of knocks them out of their, they're all spinning in a certain precession at a certain frequency. The second magnetic field kind of knocks them over, and then they kind of bounce back after you turn that off. And when those atoms bounce back, they release an energy. And that energy is picked up by this other set of coils and then through very sophisticated computers, an image is generated. So you can see how, like, this is like 2 orders of magnitude more complicated than CT, because that's just sort of like the view from 30,000 feet of how the thing actually depicts an image. So, knowing that, what are some of the advantages of MRI? Well, it gives you exquisite soft tissue detail. We've got very high spatial resolution with the current MRIs. You can basically generate images in any plane. You can do angiography. MRA can be done, at least in the head, in my area. You can do a head MRA. We do it without contrast. So if there's some contraindication to contrast, typically one of the most common ones we run into in MRI is pregnancy. In a pregnant patient, let's say you have a pregnant patient with a horrific headache, and you're concerned that, because she's pregnant and because of the differences in hemodynamics and things, that she might have an aneurysm. Okay, well, you can do a head MRA without contrast, and that's in fact how we usually do them. There is no radiation, as we mentioned, no ionizing radiation, and for just another comment about pregnancy, since I brought it up. Generally, MRI is safe in the 2nd and 3rd trimester. The issue about the 1st trimester is that it's never been proven to be safe, but it's never been proven to be unsafe. And just the reality is, nobody will ever do that study, and you can see why. If you think about the logistics of how you would do such a study, you'll see why that study will never be done. But what I can tell you is that our body imaging colleagues frequently do MRI for appendicitis in pregnant patients when they don't want to do a CT because of the radiation. So it's very common for the ER to request a pelvic MRI or an MRI of the appendix in a woman that they think, 1st trimester woman that they think might have appendicitis. And, we never hear of any problems directly related to that. Now, of course, you all know enough about the statistics to know that, some pregnancies are going to go on to have problems, obviously. And, can you go back and try to tie it to a certain cause? Well, it all becomes very loose at that point. But nothing has ever been, it's never been shown to be unsafe. Now, from my standpoint in neuro applications, basically the way we address it is that if it's something that is not emergent, like acute appendicitis, if it's somebody coming in for, let's say, like chronic back pain or something like that, I'd rather not do it in the 1st trimester of pregnancy if we can help it. But again, of course, it's always that risk-benefit kind of thing. If it's a life-threatening thing, then we'll think about it. Now, aside from that, contrast, though, is contraindicated throughout pregnancy. At all points in the pregnancy, we do not give MRI contrast at any point. Okay, so even if it's, late 3rd trimester, we don't do MRI with contrast because that is contraindicated. So how do we, with MRI, we are trying to optimize our look at different types of tissue, but for that, we actually are doing different pulse sequences for each different thing we're trying to look at. So as opposed to CT, you remember where we just did the one CT, we did it the same way every time essentially, and then we go back and we're just manipulating the data afterwards. With MRI, we have to prescribe ahead of time how we want to look at the brain, because every pulse sequence, T1, T2, et cetera, is a separate acquisition. And each of these acquisitions might take, anywhere from, 30 seconds for diffusion to say like, 6 minutes or something, for, like a spin echo or something like that. And that's why with MRI, it's more crucial that we have as much information ahead of time, before we do the study as possible, because with MRI, there's a lot more, sort of a lot more latitude for us to customize our approach to how we do the imaging. And I'll show you some examples of that. Whereas for CT, there's only so many variables. We're basically going to do, like an abdomen CT without and with contrast is basically going to be done the same way for, 90% of the patients who come in for a CT of the abdomen. Some of the disadvantages of MRI, we get very complicated artifacts that have to do with all kinds of things from metal to flow dynamics of CSF, of blood, of all kinds of things can cause really funny artifacts. Of course, there's the issue of claustrophobia. In the offices, we do give patients IV sedation. We give them IV Valium when they need it. But again, it adds another step, and it's just another thing to factor in. Certainly, it takes a little longer. To do a head MRI without contrast, say takes maybe 25 minutes. To do a head CT without contrast takes about 25 seconds. And I'm not factoring in, getting the patient on and off the table and all that, obviously. But and then with MRI, there's safety issues that, again, the list of sort of safety concerns that we have to go through before an MRI is much greater than before a CT. Essentially, with a CT, we're concerned about pregnancy, we're concerned about renal failure for the contrast, and that's about it. Where with MRI, there are a bunch of things that cannot go in the MRI scanner safely. Now, classically, pacemaker obviously has been the most commonly encountered of these, and I will tell you that I saw a press release a few months ago. Medtronic has finally put out an MRI-compatible pacemaker, but I haven't seen any more about that. I haven't seen it in any patients. We haven't been asked to image anybody yet with one of those, but that is obviously coming. So, this is one of the reasons why sometimes you'll get hassled by us. We'll call your office and we'll say, this patient told us that they have a stapedial implant. They have a stapes prosthesis, but they don't know when it was put in or where or what type it is. Can you tell us? And be like, well, what do you. The reason we do that is because we have databases where we can go through by model number, by manufacturer, by series, by the whole deal. We can look up all these different things that have all been tested, and we can tell which ones are MR compatible and which ones are not. Like with middle ear implants, there's this one thing, the McGee piston stapes is like the one that you cannot put in the MR scan. If you put it in there, it's ferromagnetic, and if you put the patient in there, it'll get twisted and it'll get knocked out of position, but all the others are safe. Well, so for us, we need to know what kind they have, because we obviously don't want to make the patient worse. We don't want to put them in there with something that's MR incompatible. Most aneurysm clips that have been put in anywhere reputable in the past 10 years are MR compatible, because the docs realize that the patient will probably need to have an MR in the future. But we need to know, what type of aneurysm clip was put in and when and that kind of thing. So sometimes it does take a little extra research of, getting the surgical records and so forth. And, it is a hassle. And, we're sorry when we have to involve you in that. But obviously we just want to do what's best for the patient and not make them any worse. Metallic foreign bodies, obviously, people come in with, like a BB behind their eye from when they were a kid, or, gunshot, in their back or something. A lot of that stuff we look at on a, kind of case-by-case basis. And I will say, occasionally we still get calls where somebody will call and they'll say, like somebody will come in for a lumbar spine CT, and I'll call the office, and I'll say, well, are you sure you wouldn't rather have an MRI? And they'll say, well, I know MRI is better, but the patient has a hip replacement. Okay, well, that's just a matter of education to understand that not all metal is contraindicated in the MR scanner. Hip replacement, even if it's made out of completely ferromagnetic material, it's not going anywhere. It's not going to move. And it's not going to hurt the patient. It's going to create a horrendous image if you try to do an MRI of their hip. You're just going to see a big black cloud there. But you can do an MRI of their head or their lumbar spine or anything, and they're completely fine. So there's a lot of detail that unfortunately we have to get into before imaging with MRI. And just something to keep in mind. It's obviously sounds simplistic, but it's true. Just because MRI is more sophisticated and more expensive doesn't mean that it's always better. With CT, there are a lot of advantages. It's very accessible. There's a lot more CT scanners around than MRI machines. It's cheaper. In general, if you want to estimate or if you want to tell your patient, in general, head-to-head, like a head CT without, an MRI head without, head CT with, MRI head with, it's about a twofold difference in general as far as the charges. MRI is about twice as much. The speed of CT, it's very quick, obviously, which we don't run into the issues with claustrophobia. Because remember, CT is like a donut. It's not a tube. It's just a donut. And the patient goes in and out really fast, whereas with MRI, you're in that tube and you have to stay in there for a while. CT is much better for showing bone detail, because basically on MRI, the bone is just black. With CT, we can manipulate those windows and levels to get much better detail. And when I say better for blood, I should be more specific and say it's better in the situation of acute subarachnoid hemorrhage. Okay, so if somebody, with the thunderclap headache, the worst headache of their life, acute onset, CT is still your best study. It's still the best place to start, because you can have a small amount of subarachnoid blood in your brain and either not see it on MRI, it might not be visible, or it might be completely indistinguishable from, say, a flow artifact related to CSF pulsating up and down in front of the pons or something. So, it's fortunate that for the life-threatening indication of suspected subarachnoid hemorrhage from aneurysm rupture, it's fortunate that the best test is also the quickest, easiest, and cheapest test. In general, I would steer you towards CT as a first line for acute problems. So, sudden onset of headache, head trauma, head injury, sudden onset of whatever it is, dizziness, sudden onset of weakness, all these kinds of things. I would steer you toward head CT first, because, again, you can get it a lot faster. You can get it easier from a logistical and scheduling standpoint. There is not all of the upfront, have they ever had metal, and have they had surgery, and blah, blah. We don't have to go through this whole litany of safety precautions, all these sorts of things. So go to CT first, because the CT is still a great screening test, essentially, for MR. If the head CT is stone cold normal, and you still have a high suspicion of a problem, then you can step it up to the MRI. But there's a lot of things that you can exclude with a CT. And also, it helps a lot for just patient reassurance. Patient comes in and says, I have this headache and I'm afraid I have a brain tumor. Well, the reality is the CTs are good enough that, if the CT, even without contrast, if the CT is normal, I can tell you that there's almost zero chance that there's any kind of brain tumor in there at all. I mean, you could have some kind of very low-grade glioma that's small, that's hiding somewhere, but you're not going to have any kind of significant brain tumor on a head CT hopefully that we're going to miss. An example of CT being preferable for bone, you can see the detail here in the left sphenoid wing there. This is fibrous dysplasia, just to kind of throw out a few examples, just to keep it germane. CT gives us nice ability to do like these 3D reconstructions for, say, this kid has a metopic suture synostosis. So he has this ridge kind of running down the middle of his forehead. You can't really, well, it's very difficult to make sort of this kind of an image with an MRI, but with CT you get the nice bony detail, and then you can also do these 3D reconstructions. This is a CT of the temporal bones. This is a great case. This is a young kid who has pulsatile tinnitus, okay, and the ENT ordered this study appropriately to know what is this retrotympanic mass that I'm seeing on physical exam. So, he's got his, he's looking in the ear there, and he sees this red thing basically behind the lower half of the TM. And rather than sticking a needle in it, he figures, well, let's get a temporal bone CT first and find out what it is. What this is an aberrant aberrant left internal carotid artery. Let me get this to pop up here. Actually, I got the image flipped. It's a right side, but it's an aberrant internal carotid artery, which is basically like a normal variant where the ICA swings out more lateral in the horizontal petrous segment before going through the skull base. So what you're actually looking at here is this is the carotid canal, okay? This is the carotid artery, and you basically see there's kind of no bony covering around this. It's just basically the vessel wall. This is the tympanic membrane. These are the ossicles here. This is the middle ear cavity. This is the external auditory canal. This is the cochlea, just to orient you. So as he looks in here, this is the tympanic membrane, and the lower half of the tympanic membrane has this bright red mass behind it. Well, that bright red mass is the internal carotid artery. So if you stick a needle in that, obviously it's going to have disastrous consequences. This is obviously somebody with bad trauma and frontal bone fractures. Here's the same CT now where we're looking at it with bone windows and then with brain window, right? So on the one, we get the detail of the fracture. And with the other, we see the subdural hematoma, the pneumocephalus, a little bit of air in the head, and then the hemorrhagic contusion as well. This is hemorrhage in the brain parenchyma here. So again, same CT looked at two different ways. This is a massive subarachnoid hemorrhage from an aneurysm rupture. This is what an infarct looks like when it's acute, but it's beyond the sort of hyperacute stage. This is obviously not a subtle infarct, but this is still in the acute phase, where basically the entire right middle cerebral artery territory is infarcted. And you can see the reason it's, again, remember what we talked about earlier with CT, it has dropped in density. It has become darker because it's edematous. This is all sort of edema in the brain parenchyma. This is all tissue that is destined to just basically to die here. This will all be encephalomalacic here. Remember, black is the water, the ventricles, and we set up our windows and levels so that you can see even though there's fluid in the ventricles and air in the sinuses, they both look black on the CT image because they're both below, that range essentially. So this is a list of some indications and some reasons why a CT would be preferred, and that's in your handout. MRI, on the other hand, is generally better for chronic problems. This is multiple sclerosis. You can see all these lesions in the pericallosal, periventricular, subcortical white matter. We use MRI to better characterize abnormalities that we initially see on a head CT. This, again, head CT without contrast. Abnormality is fairly obvious. And then we look at it on MRI. This is a T1 weighted image with contrast. You can see that the capsule enhances here, and the central part of it is sort of cystic or necrotic. And then this is the T2 weighted image. You can see all this white stuff here is edema, just like fluid in the ventricles. This is fluid in the brain parenchyma. This is edema surrounding the lesion. You can see it is slightly darker on this MRI image because, again, that's the way fluid is going to look on a T1 versus a T2 image. And again, with MRI, these are acquired as separate acquisitions. So, this took 5 minutes, then this took 5 minutes. So it's like a very different procedure. And this is a brain abscess. MRI is great for confirming acute infarct. And when you order that, you're typically going to order that along with an MRA. In this case, this is somebody who you can see, this is a diffusion-weighted image. Again, an ugly MRI image. Is not aesthetically pleasing at all, but it's incredibly sensitive for demonstrating areas of cytotoxic edema, which, when in the proper distribution, tell us that it's an acute infarct. This is an acute infarct of the left lentiform nucleus and actually involving the left caudate head as well, which is a little unusual. And when we do the head MRA, you can see here that the left middle cerebral artery is just completely truncated. This over here should look like this. You're looking at the MRA from the back, where these are the vertebrals, the basilar, posterior cerebrals. These are the ICAs coming up, anterior cerebrals up here, and this left MCA is just basically thrombosed. And the reason all this other stuff isn't infarcted is that it's being supplied by leptomeningeal collateral arteries that are coming over the surface of the brain to keep that alive. MRI is, of course, preferred for metastatic disease. In that case, you would order with contrast. This is just a small metastatic lesion that you would probably not see without contrast, and you would almost definitely not see on a head CT. So again, this is like the CT list that I showed you earlier. Just sort of a short list that you have in your handout of situations where head MRI is preferred. Short list where CT is preferred. How much time do I have, Bill? How are we doing? Okay, good. Okay. Don't worry, I won't take the whole half hour. I don't know if anybody has shown you this yet today, the ACR Appropriateness Criteria. With all these sorts of decision support issues, one place that I can confidently steer you for, valid information and the same information that we're going to give you essentially is the ACR website. And if you can find that at acr.org. You go to their website, and then you'll find right up here, at least the way the homepage is configured currently, you'll see the ACR Appropriateness Criteria. And if you click on that, you'll go to this page. And this might be worth bookmarking, in your office, on your PC or whatever, because you can go down to this list, diagnostic imaging tools, and you can see it's broken up by, breast, cardiac, GI, MSK, neurologic, pediatric. So you go down to that list, you pick your organ system, and then you pick your clinical indication. And then what it'll give you, first of all, it'll give you a narrative, like several page write-up of, okay, this is how we arrived at these conclusions, and this is what we're thinking here. But they break it all down into these very easy to interpret tables, where essentially they'll take, first of all, the clinical indication headache. And what they do is they break headache up into different categories. And for those of you who were here last year, what I presented last year was how to work up headache, depending on what type of headache it is. Well, the ACR breaks it up into 8 different kinds of headache. Here you see variant 1, chronic headache, no new features. Variant 2, chronic headache with new features. So in other words, somebody has chronic headaches, but they come in and they say, these headaches, I've had them for 10 years, but they're becoming more frequent, or they're becoming more intense, or they're lasting longer when they happen, or now when I get a headache, I get blurred vision. I didn't used to get that before. So you look at these tables, and basically what they do is they rate all the different imaging modalities on a scale, and in decreasing order, where they show you what's most appropriate and what's least appropriate and why. Okay, and this is can be extraordinarily helpful, and then it has these great sort of comments in here as well to kind of round out the information. Just a couple sort of specific clinical scenarios that I want to mention to you. Excuse me. The first is hearing loss. Very common problem, hearing loss, especially in the elderly. And essentially with the imaging, we try to follow the lead of the clinical in how we break this up. And when you see somebody with hearing loss, essentially the first fork in the decision tree is this conductive hearing loss, or is this sensory neuronal hearing loss, or sensory neural hearing loss. If it's sensory neural hearing loss, then our recommendation is to do an MRI of the internal auditory canals without and with contrast. And the idea there is that for somebody with a sensory neural hearing loss, we're looking for, say, a vestibular schwannoma, acoustic neuroma, possibly a meningioma, some kind of lesion of the internal auditory canal or cerebellopontine angle that's affecting the 7th or 8th cranial nerves. Now, on the other hand, somebody with conductive hearing loss, it's going to be more a problem with the ossicles, right, with the function of the ossicles, and something going on more like in the middle ear, usually. So for that, we recommend a CT of the temporal bones, because that'll give us the detail like you saw before with that temporal bone CT image I put up. That'll show us problems with the ossicles. That'll show us if they have, like, for instance, a cholesteatoma or some other kind of mass that's affecting the function of the ossicles in some way. They might have a fracture with ossicular dislocation, but that's one of the first forks in the decision tree there. Another very common problem that people present with is visual loss, and this is one of my favorites, because I just like thinking through this, and I like teaching people about it, because from a standpoint of neurology and how we're all how we all work and how God put us together. It's pretty cool. With visual loss, it's very common that somebody comes in for a head MRI or they'll come in, say, they'll come in for a head MRI and the clinical information will be left eye blindness. Okay, we see this all the time. And the problem is not really, in many cases, I'd say half the time, it's not really left eye blindness, it's left homonymous hemianopsia. Okay, and I'll talk about the difference. But when you're working up somebody in your office with visual loss, the first determination from our standpoint of providing the appropriate imaging is to determine whether this is pre-chiasmatic or post-chiasmatic. In other words, is it in front of the optic chiasm or is the lesion behind the optic chiasm? If it's in front of the optic chiasm, it's going to affect just one eye, and the patient will truly have left eye visual loss, right eye visual loss. If it's behind the chiasm, it's not going to affect just one eye. It's going to affect both eyes, but it's going to affect the same visual field for both eyes. Okay? So the difference for us is that if somebody truly has vision loss in one eye, we're going to do the best study that we can do for you is an MRI of the orbits without and with contrast, because we're looking for some kind of an orbital lesion, optic neuritis, retrobulbar mass, something like that. And we prescribe that study and we set it up and do it very differently than we do a head MRI. For somebody with a homonymous field cut, that patient generally needs a head MRI because we're usually looking for stroke. And often, 9 times out of 10, contrast is not needed because it's a stroke workup. Now, of course, you can have a homonymous field cut because of a tumor or something like that, in which case we would add contrast at that point. But to just kind of drive the point home, everybody kind of remembers sort of this diagram essentially where, the way our visual pathways are set up is that you have, what's to the, in this case, what's to the left of you is going to project onto the contralateral cortex, and what's to the right of you is going to project on this cortex. So if you have a visual field cut in both eyes, it infers that the problem is behind the optic chiasm, posterior to the chiasm, whereas if you can't see out of one eye, it implies that the abnormality is in front of the chiasm. So as an example, this is the most beautiful city in the world, Pittsburgh, Pennsylvania. The confluence of the Monongahela and Allegheny rivers coming together to form the mighty Ohio. And this is the only sunny day in the past 30 years in Pittsburgh. But as you look at that, as you stand on Mount Washington, where Bill and I have stood before a Steeler game, you stand on Mount Washington and you look down at Pittsburgh. What I want you to imagine is that projected, mapped out on your occipital cortex is that, right? So kind of whatever is in front of you is sort of mapped out upside down and backwards, essentially, on your visual cortex. So again, this is a diffusion MR image, ugly, ugly image, but very sensitive in showing acute infarction. This patient does not, in fact, have... Now, remember, it's going to get confusing because remember, when we look at radiographic images, this is the right and this is the left. Okay? So this patient clinically would have a right homonymous field cut. They don't have right eye blindness. They have a field cut in the right visual field of both eyes. So again, here's the patient sent in with right eye blindness. This is the initial CT. You don't really see anything. This is 24 hours later. This is kind of like what I was talking to you before about how in the early stages of an infarct, you can see it on CT because the tissue becomes edematous and it gets a little bit darker, just a tad darker. And you get this sort of situation where, in this case it's even more obvious, but you get a situation where the slightly less dense white, this is the slightly less dense white matter. Now remember, it's slightly less dense because it's fatty, right? It has myelin. It's myelinated nerves, so it's fatty. And remember, fat is less dense than water, so that's why the white matter looks less dense than the cortex, which is white, because that's more cellular, right? And in this situation, you get sort of the situation where you have this low density that includes part of the cortex and the underlying white matter. So that's your acute infarct. And It was funny, one of my sons asked me, pardon me, one of my sons asked me the other day what my favorite word was, which was kind of an interesting question because I never really thought about it, but I had to tell him homonymous hemianopsia just because I love saying that. Same, you know what it means, obviously, but same side, half not seeing. So, a couple words about spine. I know I've spent the whole time on brain, but how much time do I have now? Amy, what do we got? Okay, so spine, I'm just going to kind of abbreviate this because it's essentially all the same sorts of concepts apply that we talked about with the brain. CT is better in general, for acute problems that involve especially the bones. It's better for like intrinsic bony lesions that you're trying to work up. And of course, it's your only option when there's a contraindication to MRI. It's very good for like congenital anomalies of the spine. When we want to do those nice sort of 3D renderings or nice reformats that can show a surgeon potentially what he's going to be dealing with when he opens it up. MRI, on the other hand, that's where you want to go first. This is an exception to the acute-chronic rule that I was talking about. Acute back pain, especially in a younger patient, it really behooves you to just go straight to the MRI in most cases. If there's persistent symptoms after an acute trauma, if somebody's rear-ended and they go to the hospital and the cervical spine CT is negative, but they still have really bad neck pain for several days, that's where MRI comes in because we'll be looking for like an interspinous ligamentous tear, some kind of soft tissue abnormality that we're not going to see on the CT, or say like a cord contusion or something like that, which is not something we're going to see on CT. So anything where you're looking at the cord parenchyma, neoplasms, metastatic disease. We do a scoliosis survey protocol at our office, which has been very popular because it's a way of working up scoliosis in a young patient without any radiation exposure. So it's kind of it's sort of a limited MRI of the entire spine that we do specifically for working up the scoliosis. We don't get into detail about every little disc level and everything, but we're able to provide the necessary information for, say, an orthopedic surgeon or physiatrist about the scoliosis without delivering any radiation. Just incidentally, this is a lumbar spine. This is an acute disc extrusion, kind of small to moderate disc extrusion at L5-S1. That's kind of what they look like. It's like toothpaste squirting out. Same sort of stuff. Just kind of another sort of list in your handout that I won't belabor it. We talked about it already. Another question that comes up is the issue of contrast. And again, just as a broad guideline, what is contrast used for? Contrast is used to better characterize things that we see on the unenhanced image. It is sometimes used to detect abnormalities that are not visible on the unenhanced image. There are certain times when you're always going to want to get contrast, like if somebody with metastatic disease, like that example I showed you earlier, that tiny little lesion, you might not see that without contrast. But for a lot of people, the contrast is not needed. If it's like a vague thing, if it's like headaches or something like that, they come in, we do the head MRI, and it's negative. The chances that there's something hiding there, if they don't already have like a primary malignancy or something, the chances of needing the contrast are low. So there's a couple different ways that you can go with that, and it's kind of somewhat dependent on the workflow, the way your office functions. We do offer, in the office practice, we do offer a contrast if needed option, which basically, results in an unenhanced study, and then if there's some obvious abnormality, that the tech sees, they will call us, we'll look at it, we'll add the contrast. At that point, you've given us the authorization ahead of time for that. You can order it without contrast, and we won't bother you unless we really think we need to give it, then we'll call you and say, can we give this patient contrast? Or you can go ahead and order it without and with, And what I can tell you is if you're really adamant about the contrast being given, then just tell us that. If you're okay with us not giving the contrast if we don't think it's needed, then you can just order it as contrast if needed, or you can just communicate to us one way or another, because it's different. I mean, some doctors will send things with and without contrast. So whether we as radiologists think the contrast is needed or not, they adamantly want the contrast. So we try to customize it as much as we can for each ordering physician, so that we're kind of fitting into your workflow as best we can. So you just communicate with us and call us, and don't be afraid to let us know how you want to do that. And at the same time, please don't be too annoyed if we call you and ask you, can we give contrast or whatever. This is just like, an example of a lesion that on the, this is a T1 weighted MRI image without contrast. And you can really barely perceive this mass here without the contrast, which is, I can tell you that you would see it probably on T2 and some of the other pulse sequences, you'd see it better. But just to highlight the effect of the contrast, this is the same, level with the contrast. And this is just a benign meningioma, but it's a good example of how big something can be, and yet how inconspicuous it can be. This is carcinomatous meningitis, which is really a tricky one, because this is one that you really can miss on the unenhanced study, unless you give the contrast. So again, somebody with a known primary like breast or something like that, where carcinomatous meningitis is a consideration, they should get the contrast. So in general, contrast is indicated whenever you're thinking in terms of neoplasms, MS. We always give contrast for MS because it's very relevant whether any of the plaques are enhancing or not. Any kind of inflammatory process or abscess, infection. A patient with HIV should probably get contrast. So if you have HIV patients, please communicate that to us. Let us know when you're ordering the study, no matter what it is, whether it's neuro or body or whatever. Because as you know, the list of differential diagnoses and the list of things that we're looking for in our head is so different when we know the patient has HIV. It completely alters the way we look at the image. So it's really important to know that ahead of time, or know that in the clinical history. And then there's issues, post-operative, anybody that's had a brain tumor resected, often anybody that's had, in general for the lumbar spine, anybody that's had lumbar surgery usually gets contrast. Cervical spine, usually not. So people that have had cervical fusion generally don't need contrast just because they had surgery. But with the lumbar spine, we do contrast those people because we're looking for certain things like arachnoiditis, arachnoid adhesions. Sometimes it can help distinguish scar tissue from a recurrent disc extrusion. And then I mentioned earlier that we do head MRA without contrast, but for neck MRA, in order to get the arch all the way up, we need contrast. We can do carotid bifurcations without contrast, but to get the great vessel origins and to see the arch, we need contrast. So again, I'll steer you toward the ACR Appropriateness Criteria as a great guide. We also have a phone number in the office that you can call. This phone number goes to our Northwest Raleigh office, which is up on Forum Drive, and there's a neuroradiologist there every day, all day. So if you have questions about what to order, or if you want to review a study that was ordered and you have questions about it or whatever, that's where you can reach us. And hopefully it won't leave you, in that sort of scenario when you're trying to decide what to order. So, okay, thanks.